Very good morning, class of 2024. Today we'll be having a class on basic instruments and instrumentation in periodontics. So at the end of the topic, you need to categorize the different types of periodontal instruments, discuss the factors considered in instrument identification, explain the different types of curettes and its modification, explain the principles of instrumentation, and choose appropriate chassis portion and instrument to perform scaling and root planing. So these are the contents of the lecture. So to start with, re-establishment and maintenance of periodontal health is the main objective of periodontal treatment. Local factors like plaque and calculus are the major factors for its progression. So removal of these factors is needed to obtain a perfect periodontal health. For this, periodontal instruments have been made to achieve the desired goal. So this is a classification of periodontal instruments which is put forward in a website, so you can just go through it. So this classification is easier for us to understand what are the instruments which we use, at least at the basic levels. So first, starting with your diagnostic instruments, which includes your mouth mirror, probe and explorer. Then your scaling instrument, it could be either the manual instruments, which includes the supragingival scalers and the subgingival scalers. And then comes your power driven instruments, your sonic and your ultrasonic scalers. Ultrasonic scalers are again of two types: piezoelectric scalers and magnetostrictive scalers. Root planing instruments and curating instruments, area specific and universal curettes are there. Cleaning instruments, you have your rubber cups, bristle brushes, dental tape and air polishing devices. So to start with, the parts of the instrument include your handle, shank, and the working end. So the A part, the handle could be either at the end of an instrument or it could be at the middle of the instrument with the shank and the working end on one end or the other two ends as shown in the picture here. The handle is made in such a way that it can grasp the instrument, so it could be having certain serrations on it, so that it is easier to grasp the instrument and there's a control over the instrument. The diameter can be either large or it is small, but if it's small, it is difficult to hold. On the other hand, shank connects the working end to the handle. Now, the working end, it has a face, a back, and two cutting edges, and then the lateral surface of the instrument. So this could be different for a sickle scaler, wherein you could see the cross section is triangular in shape, and it could be different for a curette, where you can see the cross section is half moon in shape. Now coming on to the diagnostic instruments, you have mouth mirrors. It could be its main uses for retraction, indirect vision, reflex light for indirect illumination, and transillumination. You have a set of mouth mirrors which can be used according to its need. Either the plain or flat surface mouth mirrors, which we use often, the front surface mirror, the double-sided mouth mirror, and the concave surface mouth mirror. Explorers are instruments which are used to locate subgingival deposits, detect caries, and check the root surface after root planing. Periodontal probe is to evaluate the health of the periodontal tissues. So you do have this picture in Karansa as well, where you can go through and it tells about the different types of periodontal probes. So starting with the Marcos color-coded probe, here the calibrations are marked in 3 mm in 3 sections, with color coding at 3 to 6 and 6 to and 9 to 12 mm. And then you have UNC 15 probe. This is a 15 mm long probe where there is marking at each 1 mm and a color coding at the 5th, 10th and the 15th mm. University of Michigan O probe, it has Williams periodontal marking, so you don't have the 4th and 6th marking for the easy identification. Michigan O probe 3, 6 and 8, and the WHO probe, which we use for diagnostic purpose today, it has a 0.5 mm ball at the tip of the tip and a millimeter at 3.5 to 8.5.5 there is a color coding, and 8.5 11.5 has markings. The curved neighbors probe is used for the detection of the furcation areas with color coding at 3, 6, 9 and 12 mm. So coming on to scalars, basically it's used for the supragingival calculus removal with the help of a pull stroke. So scalars generally have these three characteristics in main. It has a triangular cross section, so you can see here. It has a triangular cross section. It has a double cutting edge. Both the lateral edges are cutting edges for it, and it has a pointed tip. So this is characteristic of every scalar. And common scalars includes the Jacquard scalars, Towner H15 scalar, 204S, 204SD most scalars. It could be either further classified as curved scalars and straight Jacquard scalars. So coming on to curettes, this is the instrument of choice for removing deep subgingival calculus, root planing altered cementum, and removing the soft tissue lining of the pocket. So the basic characteristics of the instrument, this instrument includes that it has a rounded blade. So you can see here this is little rounded when compared to the scalar tip, and it has a rounded tip as well. So this tip is also rounded. So it has a half moon shaped uh, cross section present. Curettes is finer than sickle scalar. No sharp points or other corners other than the cutting edge is present. It can be easily adapted and access to the deep pockets with minimal trauma. The blade appears little semicircular with a convex base, and the lateral border forms a cutting edge with the face of the semicircular blade. Universal curettes, cutting edges, this cannot be inserted into most of the areas because there are two cutting edges on either sides of the instrument. The face of the blade is angled at 90 degree when in cross section with the tip, and the blade is curved only in one direction. So these are the examples of universal curettes. Next, coming on to Gracey curettes. These are the area-specific curette angled to adapt to specific anatomic areas, provides the best adaptation to the complex and root anatomy. Double-ended Gracey curettes are available in pairs, and it's always necessary that you know this set of instruments if you want to carry on with the treatment for a patient. So here the offset angle is around 60 to 70 degree with a lower shank, and the blade curves from the head to the toe and along the side of the cutting edge, and only pull stroke can be used here. So coming on to its modification, there are two types of modifications. The 1516, it's a modification of 1112, wherein there's 1112 blade with a more acutely angled 1314 shank used in the mesial surface of the posterior, mainly for better adaptation to the surfaces from front portion with intraoral dress. 1718 is a modification of 1314, where the terminal shank is elongated by 3 mm, more accentuated shank, horizontal handle, blade 1 mm shorter, used in the distal tooth surfaces, and here the blade is 1 mm shorter to allow better adaptation to the distal tooth surfaces. There's an extended shank or an after five curette, wherein the this is an extended shank curette. So you can see that the terminal shank is increased by 3 mm when compared to the normal Gracey curette. And a mini bladed curette is one in which the blade is reduced to half its length so that it can be easily inserted into the narrow pockets, grooves, and lines. The Langer curettes, it combines the shank design of the Gracey curettes with the blade angulation of 90 degree rather than the offset angulation. So considered to be a marriage between the Gracey and the universal curettes. Gracey and the universal curettes. These are a set of Gracey curettes are a set of many curettes designed for specific areas or surfaces, whereas universal curette is one curette designed for all areas and surfaces. Cutting edge, there's only one cutting edge in case of Gracey curette, but here both the cutting edges are used. Here Gracey curettes we work only with the outer edge, but here both either the outer or the inner edge can be used. These are curved in two planes, and this is curved in one plane. Here the blade angle is around 60 to 70 degree. There is an offset angle is present, but here it is at 90 degree. There is no offset angulation present. Coming on to the principles of instrumentation, effective instrumentation is governed by a number of general principles that are common to periodontal instruments. A constant awareness of the tooth and root morphologic features of the condition of the periodontal tissue is also essential. Knowledge of the instrument design enables the clinician to select the proper instrument for the procedure to be performed and the correct area in which it can be performed. So these are the 6 principles of instrumentation as shown below. So we will go with each of them, and it's always better you follow the same uh, sequence. So, sir, first accessibility, wherein we position the patient as well as the operator gets position himself according to the patient. After that, the operator adjusts the visibility, illumination, retraction, goes on with the examination of the patient. Then, before starting the treatment, he goes on with checking of the condition and sharpening of the instruments, and sees that there is a clean field before he starts the work. And once he takes the instruments, he tries to stabilize the instrument and then activate the instrument to remove the calculus or the plug. So this is always in a sequence, and try to maintain the sequence. So coming on to accessibility, the clinician should be seated in a comfortable position. The feet are flat on the floor with the thighs parallel to the floor. The clinician should be able to observe the field of operation while keeping the back straight and the head erect. The next flexion can be around the neck flexion can be around 0 to 15 degree, not more than that. The trunk flexion can be 0 to 20 degree, not more than that. The shoulders are in a horizontal line and the weight is evenly balanced, not sitting on one side. And the upper arm position should not be more than 0. So the patient should lie in the supine position so that the mouth is close to the resting elbow of the clinician. And here, for the maxillary arch, it is a chin up position where the patient's chin is tilted a little up, and for the mandible, it's a chin down position. So these are the zones of activity for a right-handed person or operator. He will be sitting and operating from 7 to 12 o'clock position. Consider this to be a clock actually. So for a right-handed person, he will work from 7 to 12 o'clock position. 12 to 2 is a static zone, and 2 to 4 is the assistant zone, and 4 to 7 is the transfer zone. So just the reverse will be just for the left-handed person, wherein 12 to 5 is the working position, 5 to 8 is the transfer zone, and 8 to 10 is the assistant zone, and 10 to 12 is the static zone. Which we operate 8 to 9 o'clock, 12 o'clock. Again, 9 o'clock position for the areas away from the clinician with the chin down effect for the mandibular, and 10 to 11 o'clock position for the other areas. Second principle is visibility, illumination, and retraction. Generally, direct vision with direct illumination is a desirable one, but there are certain situations wherein we might not able to get a direct vision. So, for those cases, an indirect vision with mouth mirror has to be carried on, or indirect illumination where you direct the light to the mirror and that illuminates the particular area is required. So, in anterior parts of the um, parietal aspects, mainly indirect vision with indirect illumination will work out for featuring that area. Retraction is carried out using mouth mirrors or either using the fingers of the non-operating hand. Next, coming on to the condition and sharpness of the instrument. Clean, sterile, and instrument should be in good condition, which has sharp working ends. Sharp instruments enhance tactile sensitivity and allow the clinician to work more precisely and efficiently. The objective of the sharpening is to restore the fine, thin, linear cutting edge of the instrument. Sharpness can be evaluated by sight and touch, or and also with the help of light. Dull instrument generally which is rounded, which has a rounded effect like this, unlike the sharp effect of this edge. Dull instruments generally try to reflect the light, whereas the sharp instruments don't reflect the light. Drawing the instrument lightly across a sharpening test kit will show whether the instrument is dull or sharp. If it is a dull instrument, it will slide smoothly, but if it's a sharp instrument, it will bite into the surface and raising a light shade. Generally, you do have sharpening instruments, either the stationary one or the mounted devices for sharpening your instruments. Next, coming on to instrument stabilization, grasp and finger rest. The pad of the thumb is placed midway between the middle finger and the thumb finger. So this is called as a tripod effect. So here you can see in the picture wherein there is the pad of the thumb finger is placed midway between the middle and the index fingers, and all these fingers are touching the instrument. So this creates a triangular force here, otherwise known as the tripod effect. This is very important because it enhances control and enhances tactile sensitivity. It enhances control because it counteracts the tendency of the instrument to turn uncontrollably between the fingers when scaling force is applied to the tooth, and this also enables the clinician to roll the instrument in precise degrees. The next grasp is here palm and thumb grasp, which is used for stabilizing the instruments during sharpening and manipulating the air and water. Next, coming on to finger rest, this serves to stabilize the hand instrument by providing a firm fulcrum as movements are made to activate the instruments. There are four types of finger rest. They are first the conventional finger rest, wherein you can see that the finger rest, generally the right finger is for the the ring finger is used for the finger rest. You can see that it is either placed on the adjacent teeth or two or three teeth away from the site of working. So this is called as a conventional finger rest. Opposite arch finger rest, where the ring finger is placed on the opposite arch other than the area where the working is being done. So the working is done on the maxillary, but the finger rest is placed on the mandible. Cross arch, the working is done on the third quadrant. The finger rest is placed on the next quadrant, that is on the fourth quadrant. So this is called as cross arch finger rest. Finger on finger rest, on the non-operating hand, the ring finger is placed, support is taken from here, and then instrumentation is carried out. This is called finger on finger rest. Coming on to extraoral fulcrums and reinforcements for effective instrumentation of some aspects of maxillary posterior teeth, extraoral fulcrums are used. This allows optimal access and angulation while providing adequate stabilization. Extraoral palm up fulcrum, the backs of the finger rests on the right lateral aspect of the mandible while instrumenting the maxillary right posterior teeth are being instrumented. Extraoral palm down finger rest, the front surface of the finger rest or on the left lateral aspect of the mandible while working on the maxillary left posterior teeth. So this is called as a palm down fulcrum, and this is called as a palm up fulcrum, since the palm is facing up and here the palm is facing down. There are also reinforcement which can be given with the help of the non-operating hands fingers. Index finger reinforce, you use the index finger to reinforce, and thumb reinforce, the thumb of the non-operating hand is used to reinforce this instrument. Next principle, instrument activation. So generally, the very first concept in instrument activation is adaptation. That is how the manner in which the working end of the periodontal instrument is placed towards the surface of the teeth. Its objective is to make the working end of the instrument conform to the contour of the tooth surface. This is to avoid trauma and ensure maximum effectiveness of the instrument. Generally, any instrument tip is divided into the lower one third, middle one third, and the upper one third. So it's always recommended that the lower one third always touches the actormost part of the instrument always touches the tooth surface. So if it is away from the tooth surface, you can see the amount of pressure it creates on the supporting tissues. Angulation, this is the angle between the uh, face of the bladed instrument and the tooth surface. So here you can see that there is a 0 degree angulation is used for insertion. The angle between the blade and the tooth surface is completely 0, so this can be used for insertion. 45 to 90 degree is a correct angulation for scaling and root planing. Less than 45 degree is used for incorrect angulation for scaling and root planing. Above 90 degree is also an incorrect angulation for scaling and root planing, but it is an ideal angulation for gingival curettage. Lateral pressure, this is a pressure when force is applied against the surface of the tooth with the cutting edge of the bladed instrument. It should be firm, moderate, and light. While removing the calculus, lateral pressure is initially applied firmly or moderately and is progressively diminished until light lateral pressure is applied for the final root planing strokes. Repeated application of excessively heavy strokes often nicks or gouges the root surfaces. Next, coming to stroke, the direction, length, and pressure and the number of strokes are necessary for either scaling or root planing, and this is determined by four factors: gingival position and tone, the pocket depth and shape, tooth contour, and the amount and nature of the calculus or roughness. There are three types of strokes apart from the directions. The first type is the exploratory stroke, which is a light feeling stroke. It is used by the probes and the explorers to evaluate the dimensions of the pocket, to detect calculus and irregularities of the tooth surface. This is grasped lightly and adapted to the with light pressure against the tooth. Scaling stroke, it's a short, powerful pull stroke used for the bladed instruments for the removal of the supra or the subgingival calculus. You secure the grasp of the instrument correctly, and lateral pressure is firmly applied against the tooth. The third one is the root planing stroke with a moderate to light pull stroke. There's a final smoothing and planing of the root surface. Moderately firm grasp is used and even lateral pressure is used. Apart from that, you have directions of stroke, wherein if the stroke is applied in a vertical direction, if the stroke is applied in an oblique direction, or if the stroke is applied in the horizontal direction. Accordingly, the names are given as oblique, vertical, and horizontal strokes. Generally, a wrist forearm motion is to be used when you are going on for the instrumenting of the surfaces um, rather rather than the other uh, instrument movements. So this forearm is used when in a case when pivoting in an arc on the finger is, and this produces a powerful stroke and is therefore preferred for scaling. Finger flexing also can be used to precise control over stroke length in areas such as line angles, and when horizontal strokes are used on lingual or the facial aspects of the narrow rooted teeth. Instrumentation for calculus removal. Generally, when you're instrumenting calculus removal, always try to engage the apical end of the calculus or the lateral edge of the deposit for with the help of the cutting edge of the scaler. The instrument is moved laterally, again engages the second part of the calculus with an overlapping stroke, and then an upward pull motion is given. Then the final portion is engaged and it is removed. In short, try to catch the calculus when you're doing a manual instrumentation apical to the deposit, and then give a powerful pull stroke for it to be removed. There could be musculoskeletal problems when we are doing hand scaling. The reason being we would be applying more pressure without our own knowledge when we are removing the calculus. So this might lead to musculoskeletal problems like carpal tunnel syndrome, ulnar nerve entrapment, tendinitis, thoracic outlet syndrome, and lower back pain. So generally, a common complaint with the dentist is a lower back pain. This generally comes when there is a disc degeneration or herniation. Sitting with flexing while flexing forward compresses the discs in the front. Uneven pressure on the disc leads to disc bulging and herniation. When the disc bulges or herniates backwards, the nerves can become pinched. Because of this, you could get lower back pain. So, in conclusion, periodontal instrumentation is a kind of a repetitive task. That is a task that involves the same fundamental movement for more than 50% of the work cycle. So, periodontal instrumentation requires excessive upper body immobility, while the tendons and the muscles of the forearm, hands, and fingers overwork. Dentists have a high risk of musculoskeletal injury when repetitive motions are combined with powerful movements, awkward postures, and insufficient recovery time. Fortunately, injury to the muscles, tendons, and nerves can be prevented in most cases by adhering to the principles of instrumentation.